Welcome, everyone, and thank you to those joining us live and to those listening in afterwards. I'd also like to warmly welcome our guests today, whom I'll shortly introduce. I'm John Herdig, Associate Professor and Vice Chair of Pharmacy Practice in the Butler University College of Pharmacy and Health Sciences in the United States, and I will be serving as your moderator for today. FIP's vision is a world where everyone benefits from access to safe, effective, quality, and affordable medicines and health technologies. Our mission is to support global health by enabling the advancement of pharmaceutical practice, science, and education. We're so pleased to be delivering this event on COVID-19 associated complications, what pharmacists should know. This is a special event under the FIP digital program, COVID-19, collaborating through the pandemic, working and learning together. We know that the world's pharmacy team is fighting COVID-19 hard everywhere, working closely with other healthcare workers and often putting their own lives at risk to protect and care for patients and the public during these times. You can watch previous episodes of this program via our website on event.fip.org. In today's program, we will be raising awareness of the pharmacist's role in supporting patients with COVID-19 associated mold infections and long COVID. Please note, this event will be recorded, live streamed via YouTube, and be available at www.events.fip.org. To all those listening, please do feel free to send your questions through the Q&A box. And we will be monitoring those and picking those up throughout today's session. We've set aside some time at the end of the session to answer your questions. I'm now pleased to introduce our two esteemed panelists today. But first, I do want to go through our learning objectives. Participants in this webinar will, one, be able to recognize the manifestations and risk factors of long COVID. Two, provide actionable steps to care for people with post-COVID conditions as part of multidisciplinary teams. Three, discuss common manifestations and risk factors of COVID-19 associated mold infections. Four, identify prevention measures for COVID-19 associated mold infections. And then finally, recognize treatments for COVID-19 associated mold infections. We have an exciting program ahead, and now allow me to introduce our two speakers today. First is Stacy Conkle. Stacy is a member of the 2020 class of the CDC's renowned Epidemic Intelligence Service, or EIS. She is currently serving as the New York State EIS Field Officer, where she works with the Division of Epidemiology. Much of Stacy's current work focuses on various aspects of COVID-19 pandemic from both a state and federal perspective, including multi-state assessment of post-COVID conditions. Dr. Conkle completed her MPH and PhD in epidemiology and biostatistics at the University of Louisville's School of Public Health and Information Sciences, and a Bachelor of Science in Food Science from Purdue University, one of my alma maters as well. Our second speaker is Dallas James Smith. Dallas Smith graduated with his Doctor of Pharmacy degree from the University of Findlay, Ohio. After graduation, Dallas was accepted to serve with the Peace Corps as a community health educator in Cambodia for 2 years. His passion for building capacity and empowerment led him to an additional tour with the Peace Corps response program in Malawi as clinical pharmacy and pharmacognosy lecturer at the College of Medicine, University of Malawi. Due to the COVID-19 pandemic, Dallas was evacuated back to Arlington, Virginia, where he managed a COVID-19 testing site and subsequent vaccine clinics. In July of 2021, Dallas started his current position with the Centers for Disease Control and Prevention, otherwise known as the CDC, Epidemic Intelligence Service, EIS officer in the Mycotic Disease Branch. He continues to teach virtually at the College of Medicine in Malawi while being involved in various projects at the institution. Outside of work, Dallas enjoys cultivating native plants and fruits, listening to musicals, and learning about traditional and complementary systems of medicine. We're so honored to have both of these speakers with us today. And at this point, I want to turn it over to Stacy to start our presentations.
Can someone just confirm? Oh, can someone confirm you can see me and my slides okay?
I can. Thank you, Stacy.
Thank you. So hello, I'm Dr. Stacy Fungal, and I first want to thank FIP for inviting me today to talk about what is known about post-COVID conditions. I have been deployed to the CDC's post-COVID conditions team since late 2019, and I'm happy today to talk about the ever-evolving world of post-COVID conditions. During my presentation today, I will discuss post-COVID conditions, characterize the long-term effects of SARS-CoV-2 infections, discuss disability associated with post-COVID conditions, and provide links to guidance and education on post-COVID conditions. I will start by discussing what is known about post-COVID conditions. Post-COVID conditions, often referred to as long COVID by patient advocacy groups and an assortment of other names, is an umbrella term for a wide range of physical and mental health consequences. The CDC is defining post-COVID conditions as symptoms experienced 4 or more weeks after SARS-CoV-2 infection. Even persons who had initial mild or asymptomatic acute COVID infections have reported post-COVID conditions. A wide range of long-term adverse health outcomes have been described for post-COVID conditions. Direct organ damage to the lungs, heart, kidneys, nervous system have been reported. Worsening pre-existing conditions and disabilities have been described, and debilitating symptoms are frequently reported, including respiratory and cardiac symptoms, fatigue, sleeping difficulties, depression, anxiety, palpitation, joint pain, and post-exertional malaise. Of note, the World Health Organization published a clinical case definition. The World Health Organization case definition is more restrictive. Because relatively little is known about exactly what is going on in these patients, the CDC has opted to stick with a more broad definition for post-COVID conditions. But the caveat of a more broad definition for post-COVID conditions is that it becomes more challenging to study and understand. Because patients experience a spectrum of heterogeneous symptoms that include physical, social, and psychological consequences, it is hard to know what is post-COVID conditions and what may not be. Additionally, many symptoms can be attributed to other underlying conditions. Formally studying post-COVID conditions has become a challenge, and robust longitudinal surveillance data is not yet available. It has been difficult to discern a clear signal from the current literature. Many of the current studies are among different patient populations, assess different time points in illness, are generally cross-sectional and do not always include the same set of symptoms, and do not consistently report on outcome measures of the impacts of the symptoms, such as quality of life. Post-COVID conditions could affect millions of Americans. Frequency estimates vary widely in the literature. Current estimates range from 13.3% at greater than or equal to 28 days to 4.5% at greater than or equal to 8 weeks to 2.5% at greater than or equal to 12 weeks among non-hospitalized and hospitalized persons. Among cohorts of individuals who were hospitalized during COVID, prevalence estimates for post-COVID conditions range from 33% to 88% at 6 months and 30% at 12 months. The duration of these post-COVID symptoms is largely unknown. Estimates from the UK report 1 in 5 persons may have symptoms for greater than or equal to 5 weeks, and 1 in 10 may have symptoms for greater than or equal to 12 weeks. Evidence that new diagnoses of shortness of breath, fatigue, nonspecific heart rate abnormalities, and cognitive dysfunctions are more common among hospitalized adults and children with positive SARS-CoV-2 tests compared to children with negative SARS-CoV-2 tests. New or persistent symptoms, which are symptoms lasting for greater than 4 to 6 months, may occur among patients with COVID-19 regardless of acute illness severity. Severity of persistent symptoms and the proportion unable to resume work or normal activities is unknown. It is likely that the health disparities that put certain segments of the population at higher risk for SARS-CoV-2 and severe infection may also be at higher risk for post-COVID conditions. These populations include racial and ethnic minorities, older populations, rural residents, and individuals with clinical complexities, including persons with pre-existing conditions, severe COVID-19 infections, mental health history, and women. Cohort data and national survey data confirm that post-COVID conditions are occurring in children, but it continues to be difficult to ascertain attribution to infection. The figure here shows results published from a prospective cohort study of children admitted with suspected or confirmed COVID-19 to a children's clinic in Moscow, Russia. The results indicate older children and allergic diseases were risk factors for developing post-COVID conditions in children, and that post-COVID conditions in children are similar to those seen in adults. It is important to consider the impact of post-COVID conditions on quality of life, which include limitations in physical activity, feeling distressed about symptoms, mental health changes, and decreased school attendance or participation. Additionally, non-hospitalized children can experience post-COVID conditions, but are reported less frequently than in adults. In a national survey, 4.4% of children versus 13.3% of adults reported symptoms lasting greater than 28 days, and 1.8% of children versus 4.5% of adults reported having symptoms lasting greater than or equal to 2 months. Symptoms in children may be more mild and therefore less likely to be identified. It is important to consider post-COVID conditions in children. I think one of the areas that has gotten more attention recently, but was overlooked for a while, was post-COVID conditions after vaccine breakthrough. It is important to recognize that regardless of vaccination status, the potential for developing or experiencing post-COVID conditions after a SARS-CoV-2 infection is possible. A New England Journal of Medicine study from Israel found that vaccine breakthrough cases generally had mild or asymptomatic infections, but that 19% had persistent symptoms at greater than 6 weeks after acute infection in the alpha variant setting. However, evidence does show that breakthrough cases are less likely to report prolonged symptoms compared to unvaccinated individuals, and vaccines prevent post-COVID conditions by decreasing transmission. The CDC is working to characterize the long-term effects of SARS-CoV-2 infection. Healthcare utilization tends to increase in adults after COVID-19 diagnosis. The most common new symptoms reported in the 6 months following COVID-19 diagnosis are cough, shortness of breath, chest or throat pain, and fatigue. These symptom reports decrease after 60 days, but do persist beyond 120 days for some patients. Long-term symptoms are common following self-reported SARS-CoV-2 infection. The most common symptoms reported are fatigue, change in taste and smell, shortness of breath, cough, and headache. Symptom onset may be delayed. 7% of hospitalized and 8% of non-hospitalized adults report symptom onset greater than 30 days after COVID-19 illness. Disability associated with post-COVID conditions. Post-COVID symptoms are not uncommon, but most patients' symptoms do slowly improve with time. A recent Nature publication reported approximately 2% of patients still reporting symptoms after 12 weeks, compared to 13% at 28 days. Reports out of China indicate that 88% of hospitalized COVID-19 patients returned to the original work within 12 months. However, the full extent and duration of those experiencing persistent symptoms is unknown. Some striking findings that post-COVID disability is immense. In my opinion, these figures are some of the most impactful numbers I've seen. Compared with patients referred to cancer rehabilitation, post-COVID patients had poor physical health. Patients with post-COVID conditions had more difficulty doing usual work or participating in activities with friends and had reduced endurance in a 6-minute walk test. In America, long COVID is considered a disability under the Americans with Disabilities Act. Guidance states that long COVID is a physical or mental impairment, can substantially limit one or more major life activities, but may not always be a disability. The CDC is providing education and guidance to post-COVID conditions. Because of the clinically complex nature, it is hard to diagnose post-COVID conditions. And there are currently no diagnostic tests available to distinguish post-COVID conditions from other etiologies. Patients may report numerous symptoms and symptoms that are not explained by testing, which can leave patients feeling misunderstood and even stigmatized. Complicating things further, to date, there is no clinical trials data or management outcomes available. The CDC interim guidance for post-COVID conditions clinical care states most post-COVID conditions can be diagnosed and managed by primary care. Complicated cases may be considered for referral to a multidisciplinary post-COVID care center. Diagnoses may be based on history or physical exams. The guidance cautions that routine testing may be normal in individuals with post-COVID conditions, and the potential for harm could arise from excessive testing. The interim guidance suggests considering a conservative diagnostic approach in the first 4 to 12 weeks. But if symptoms persist beyond 3 months, the patient should be considered for further evaluation. It is important to remember to listen to and validate patients' experiences and partner with patients to identify achievable health goals. The CDC has provided continuing education opportunities for healthcare providers via COPA calls, which can be found via the links on this slide. These calls include discussions on resources such as basic diagnostic tests to consider after SARS-CoV-2 infection, symptom inventories and assessment tools that might be helpful for monitoring the status of post-COVID conditions, suggested management strategies, clinical and public health recommendations, and recommendations for documenting post-COVID conditions. The CDC is providing educational web pages for the general public and patient toolkits, which can be found via the links on this page. These web pages include great explanations of post-COVID conditions for the general public on topics such as types of post-COVID conditions, children and adolescents with post-COVID conditions, ways to cope with stress, and caring for people with post-COVID conditions. The patient toolkits provide guidance for patients about preparing for doctor's appointments to discuss post-COVID conditions. A healthcare appointment checklist is provided. Guidance on writing a brief medical history is discussed. An overview of what to expect during the appointment is available, and tips for working with healthcare providers are discussed. There are a number of advocacy and professional groups established to share patient and clinical experiences. Several federal agencies are engaged in sharing information and coordinating activities, and the WHO is working towards developing consistent terminology and definitions. New or persistent symptoms are not uncommon. Even people with asymptomatic acute COVID-19 infections may develop post-COVID symptoms. The full duration and extent of impairment varies, and it is not well understood or documented. We will continue to seek clarity on the frequency, severity, duration of post-COVID conditions, identify groups that are disproportionately impacted, and models of healthcare that assure equity, and how variants and vaccinations influence incidence of post-COVID conditions. There is a lot of work to be done surrounding post-COVID conditions. Given the size of the pandemic, even a 1% disability will have a huge impact. We need to continue to build capacity to address post-COVID conditions through a full public health approach. We need to provide prevalence and incidence by specific demographic subgroups, characterize the epidemiology, course of illness, and risk factors, provide guidance for clinicians, and establish and maintain partnerships with all parties, including clinicians, professional societies, affected populations, the public, and other federal agencies. Thank you for your time, and I look forward to your questions at the end.
Thank you so much, Stacy. Post-COVID conditions are ever evolving, and so we're really fortunate to have experts like you helping analyze the impacts of post-COVID conditions to our patients worldwide. So thank you for sharing your insights. We'll look forward to Q&A after the next presentation. Speaking of the next presentation, it's my pleasure to invite Dallas Smith to go ahead and start sharing his slides. Take it away, Dallas.
All right, can everyone see my slides okay?
I can, Dallas, they look good.
Perfect, thank you so much for the introduction, John. So today we're gonna transition a little bit, and I wanted to discuss COVID-19 associated mold infections. Just because in the media, we've been seeing a lot of these reports, and they've been pretty concerning, and they've been all over the world. So we've seen this deadly coronavirus triggered fungal infection report in India. We've seen Brazil. We've seen in the US, we've seen all over the world about these fungal infections that have been associated with COVID-19 infections. And so they just keeps going on and on and on. And the reason we're worried about this is that it's a huge, important public health problem, and one that pharmacists can have a pretty huge role in helping to control and contain. So there's this great study done by IDSA, it was completed in the United Kingdom, but it looked at individuals in the ICU who had COVID-19 and was looking at the prevalence, or how many fungal infections were prevalent. So out of 135 adults in the ICU, 27% of those individuals developed fungal infections, which is a very, very high rate. And out of those 27%, 14% developed invasive Aspergillosis, which we'll be talking about today. And the other 13% had invasive yeast infections, more specifically some of the Candida species like Candida glabrata or Candida albicans. And when we looked at the outcomes of these fungal co-infections with COVID-19, we saw very, very high mortality rates. So when we looked at those among COVID-19 patients with fungal diseases, the mortality rate was around 53%, versus those with just COVID-19, it was around 31%. So that's a huge gap, an increase in mortality when patients have COVID-19 on top of fungal diseases. And one of the biggest problems that we've seen is that some of these are misdiagnosed or underdiagnosed. And so if we do not treat these fungal diseases in patients with COVID-19, we see up to a 90% mortality rate, which is very high. And this is why it's important for us to be raising awareness of these fungal diseases so that we can provide treatment for these patients. And just in red down at the bottom, out of this article, one of their main recommendations is that we need to be able to look at structured invasive fungal disease testing so that we're able to diagnose these infections quickly so that we get them the treatment that patients need. So the first COVID-19 associated mold infection I'll be talking about today is COVID-19 associated pulmonary aspergillosis, or we just call this CAPA. It's a much shorter and much easier to read. So when we talk about aspergillosis, we need to understand where the disease and where the fungus that causes aspergillosis comes from. So what happens is that we are exposed to spores that causes aspergillosis, and these come from the soil. They come from decaying vegetation, from seeds, from grains, and we inhale these spores daily. But normally it's not a problem in immunocompetent individuals. We start seeing problems when these spores are inhaled by individuals who have immunosuppression of some sort. And these spores can contain different Aspergillus species. Some of the most common ones are Aspergillus fumigatus, Aspergillus flavus, Aspergillus niger, and there are several other ones. But the most common one and the one we're most usually worried about is Aspergillus fumigatus. And these spores can be picked up and breathed in both indoor and outdoor because it's just very common in the environment. So have we ever seen this before? Have we seen CAPA before? Have we seen COVID-19 or some type of disease-associated pulmonary aspergillosis? So we've actually seen some reports that we've had invasive pulmonary aspergillosis in severe influenza cases. And so these patients are in the ICU, they're ventilated, and they end up developing a influenza-associated pulmonary aspergillosis. So this isn't completely new to us, but we've seen really high rates throughout the COVID-19 pandemic. And just like CAPA, COVID-19 associated pulmonary aspergillosis, we've also seen that there's been a low awareness and infrequent testing by clinicians when it's associated with influenza. And throughout the last year and a half during this pandemic, we've seen a huge amount of reports of CAPA. And this is mostly from Western Europe, but we've seen it spreading through areas all across the world. So what are we looking at in terms of incidence and mortality with CAPA? So there was a study done that it looked at estimated CAPA incident rates for severe COVID-19 patients who are actually receiving mechanical ventilation. And of those patients who were on mechanical ventilation, 10% was diagnosed with CAPA, which is a pretty high number for those at-risk patients. And then if we transition to what is the excess mortality rates for COVID-19 patients with CAPA versus COVID-19 patients without CAPA. And this could range anywhere from 16 to 25%. So this is individuals who have COVID-19 and this fungal infection. They can have higher mortality rates up to 16 to 25%. So who are the patients getting CAPA and who are those most at risk? So we normally see CAPA in individuals who are critically ill. These are the patients who are ventilated. They're the ones in the ICU. And these are the ones that are going to have a very high mortality rate. It's not going to be individuals who have a mild COVID-19 infection. It's going to be those who are in the ICU and having a lot of problems. So some specific risk factors that we've identified for CAPA are advanced age, so greater than 60 years of old. We've also seen it in comorbidities like diabetes, hypertension, chronic kidney disease, or acute kidney injury. From a pharmaceutical perspective, we've also seen the overuse or prolonged use of steroids as a risk factor, and also other immunomodulating agents, specifically some immunotherapy agents. We've also seen CAPA have higher incident rates in those who are using a ventilator for longer than needed, or also ECMO. And ECMO is extracorporeal membrane oxygenation. ECMO is just a machine that pretty much breathes for a patient. And also we've seen higher CAPA incidents with inappropriate use of empiric antibacterial agents. And one of the biggest problems that we have is how do we diagnose CAPA? And the reasons that it's difficult is that the symptoms are pretty non-specific until it gets really severe. So it maybe look like another pulmonary illness, another pneumonia. And also radiology doesn't really tell us much. It's also difficult, if we do get a positive result, it's difficult to distinguish between colonization, which means we just have it, but it's not causing any symptoms, versus an actual full-on invasive infection where it's actually contributing to the disease state. And this is really because this mold, we breathe it in every day. So most likely, most of us are colonized right now, but it's not causing any disease because our immune system can keep it at bay. So when we do try to diagnose this, we normally require special laboratory testing. And this is not routinely ordered unless there is a suspicion of fungal disease. And two of our main markers that we use is galactomannan and also beta-D-glucan. And these are cell wall antigens that are unique to fungus. Another problem with diagnosing these fungal diseases is that fungus look a lot like human cells. So we need to find specific entities within the fungal cells that are unique to fungus and not look like human cells. So these are their two main targets, is galactomannan and beta-D-glucan. We can also look at histopathology. And when we collect samples and when we want to culture these mold infections, we need to do it on a deep respiratory specimen. So we can't just do a sputum. Usually it's something really deep in the pulmonary tract in order to get a good specimen so that we can run tests on it. However, because of COVID-19, these are collected less often because there's a high risk of transmission to the one actually collecting the specimen. So transitioning to treatment of CAPA, we're really looking at a lot of our triazoles. And we are preferring IV formulations, mostly because we're going to be able to avoid malabsorption and any gastroparesis problems. So we normally are avoiding the oral agents and typically going with the IV agents. And our mainstays of treatment for CAPA are these voriconazole, isofluconazole, and posaconazole, which are our newer triazole agents. And one of our favorites that we can use is isofluconazole because it's less liver problems. It doesn't cause neurotoxicity or less chance of it. And it decreases the risk of QT prolongation compared to the other newer triazole agents. However, when we see that we have a resistant strain of CAPA, we want to consider amphotericin B, and we want to make sure, if possible, that we use the lipid formulation just because it's easier on the kidney. I also wanted to note that echinocandins can be considered as add-on therapy, especially in refractory disease, but it should not be used as a standalone agent at this time. One thing I wanted to mention is that we are seeing a lot more resistance in our Aspergillus fumigatus species. And this is, as I mentioned before, is the most common cause of CAPA. we're seeing this pan resistance to azoles, or even our newer azoles, and it's a pretty growing concern. And one of the factors that is driving this increased resistance is from the environment. So there's really two ways to acquire this resistance. One way is what we commonly think of is that we treat a patient with a triazole who has Aspergillus fumigatus, and we think the infection is clear, so we stop them. And however, there's some mold left, and it becomes resistant, intrinsically resistant, because we didn't treat all of it. And that's kind of our normal route for obtaining resistance to Aspergillus fumigatus. However, in the last 5 to 10 years, we've been seeing this other route where in the environment, we're using a bunch of fungicide that looks like our triazoles that we treat humans with. So we're using these fungicides to help our plants grow better, to make sure we get good harvest. However, because these fungicide looks like our triazoles, this is allowing Aspergillus fumigatus in the environment to acquire resistance. So now we're seeing patients who have never taken a triazole before, who are now infected with Aspergillus fumigatus, and they have resistance due to this environmental exposure. And when we see these patients with this resistance in Aspergillus fumigatus, we see a 33% higher mortality rates than just a regular Aspergillus fumigatus infection. And in the US, the prevalence isn't really known how common a resistant Aspergillus fumigatus is. However, there's been really great studies in Europe where it ranges from 7 to 19%, depending on the country, which is pretty high prevalence and something we're really concerned about. And it'd be nice to get a better handle on what the prevalence is across the world. And I wanted to share some resources with you around CAPA. These are resources ranging from guidelines all the way from interactive continuing education development activities, and just a lot of information on aspergillosis associated with COVID-19. So now we're going to switch topics. We're still going to stay on mold infections, but we're going to transition to COVID-19 associated mucormycosis, and we are calling this CAM now. So we have acronyms for everything. So I'll refer to this as CAM here on out. So when we look at how mucormycosis is caused and what causes it, we see a similar pattern as with CAPA. So we have these mucormycetes, which are found in soil, and they're associated with decaying organic matter, such as leaves, compost piles, animal dung. And just like Aspergillus species, these mucormycetes, we come in contact with these every single day. And just like Aspergillus species, it's usually not a problem unless we are immunocompromised. There are several different agents or several different species of mucormycosis that can cause, there's several different species of mucorales that can cause mucormycosis. And some of the most common ones are this Rhizopus species, and the most common subspecies is Rhizopus orzali. And this is what we see most often in mucormycosis cases. We have other genera that we see that actually cause mucormycosis, and this ranges from Mucor species, Rhizomucor species, and I just listed a few other ones, but the most common ones are these Rhizopus species. And I do want to mention that we often hear mucormycosis and the agents that cause them, we refer to them as black fungus. However, mucorales species, the ones that cause mucormycosis, are not actually black or brown fungi. They're actually a different color. The reason that we call mucormycosis a black fungus is that that's how it appears on the skin or on the patient. So usually the black appearances of lesions appears on the patient. So it's a bit of a misnamed disease and fungus. So mucormycosis should be treated always as a medical emergency. And this is because it can cause a wide range of presentation. So some of the clinical forms that we've seen is rhinoorbital cerebral disease, which is when it could infect the eye, could infect parts of the CNS. We also see it as a pulmonary disease on the skin and other sites. And I've posted a few pictures down below just to give you an idea of the wide range of presentations it can have. And just like CAPA, it's pretty difficult to diagnose. So we normally utilize a variety of approaches. So we look at clinical, microscopy, radiography, and histopathology. And if we even suspect mucormycosis, we should be treating it right away. We should not be delaying treatment just because this is a medical emergency. We've seen rates of mucormycosis, mortality rates, as high as 50% with this disease. So when we look at risk factors for mucormycosis, some of them align quite well with CAPA. So one of the biggest ones that we've seen recently in particular is poorly controlled diabetes. We've seen some hematologic malignancies, some stem cell transplant. And as with CAPA, we've seen these overuse or misuse of steroids or other immunosuppression agents. And so we also need to keep in mind that mucormycosis is an emerging concern in patients with current and recent COVID-19 infections. So these infections don't have to occur right after or during their COVID-19 infection. It can occur a week or so after. Maybe they might be released from the hospital. So we need to follow up with these patients as well. So when we think about treatment for mucormycosis, we generally require 3 different aspects. The first one, and probably the most important, is we need an early diagnosis. This helps us, diagnose and get treatment started early, and it also improves outcomes. Typically, drastic surgery is also needed, and this is accompanied with antifungal therapy. However, when we think about what's available at the hospital or the health facility where this patient is being seen, we need to take into account both drug availability and also ear, nose, and throat surgical capacity. And another thing we can be doing, especially as pharmacists, we need to be advocating for the control of the underlying disease state. And this is typically going to be uncontrolled diabetes, and which can help improve outcomes. So when we look at antifungal therapy and how do we want to treat mucormycosis, therapy is typically centered around polymers, and our main polymer that's being used is amphotericin B. And we prefer the liposomal just because it's easier on the kidney and causes less side effects. However, sometimes that's not available, so we just need to use amphotericin B if we have it. And the reason we don't want to use azoles or triazoles is that mucormycosis is caused by a variety of different species, which I mentioned before. And some of these species have poor in vitro activity when azoles are used. So we don't want to use azoles just because the species may not be able to be cured or have activity with azole use. Some alternative options that may be used depending on the species are these extended spectrum azoles, or our newer triazoles. And this is really isovoconazole and posaconazole. And especially if a patient has poor renal function and amphotericin B is going to exacerbate those issues, we may consider these agents to protect the kidney. Also, for adjunct therapy or add-on therapy, we can consider echinocandins. There's not a lot of data out there that supports the use of it, but these patients are typically going to have very severe disease, so we want to make sure we use whatever we can to help them. And just as a summary slide, and kind of what we're dealing with right now with mucormycosis, we are seeing global reports increasing. And this was particularly prevalent in India right now in the last couple months. And the cases in India have been really interesting. So we're kind of looking at what are possible reasons for the increase in CAM cases. Is it environmental? Is it diabetes? Is it prevalence of overuse of steroids? Is it a large COVID-19 case burden? And it's probably a mix of all of these. We also have inpatients and outpatients affected, which is pretty concerning because a lot of patients are getting using a lot of steroids on the outpatient basis. and then they're misusing them or using for too long, and then they might be getting infected with CAM. And so India and their government declared CAM a reportable disease. So if you look at the literature, you see a lot of case reports being published. And because India is taking this very seriously because it is a medical emergency. However, something interesting we've seen is that the case fatality rate for mucormycosis is around 5%, which is much lower than expected. As I mentioned before, we've seen as high of rates as 50%. However, we're seeing about 5% mortality rate in India currently. And we've seen cases in the US, Pakistan, Brazil, Chile, and others. And when we look at these cases, we're seeing a higher mortality rate and more severe disease. So we're kind of trying to understand what's going on here. However, regardless, we still need more surveillance, and we need to better understand the diseases from other nations across the world. And I just wanted to throw some other CAM resources at you, just because it's always good to be aware of the diseases and the most current literature on it. And as a fellow pharmacist, I wanted to end on some pharmacologic considerations for both of these mold infections, so for CAPA and CAM. And I wanted to point out this really great resource, this COVID-19 associated fungal infections educational initiative. And it has a care step pathway that really helps in diagnosing, treatment, and considerations for CAPA and CAM. So I'd really recommend checking out this resource here. So when we think about CAPA and CAM, and what should we consider from a pharmacist perspective, we need to take into account pharmacokinetics and pharmacodynamics. So particularly with pharmacokinetics, most of these patients are going to have severe COVID-19, which means they're going to have a lot of things going on in their body that's going to affect their pharmacokinetics. So they might be on ECMO, which is this extracorporeal membrane oxygenation, which means a machine is breathing for them. And this is going to affect how well the drug is distributed, what's the volume of distribution, et cetera, et cetera. We also need to think about renal toxicity. Severe COVID-19 disease can cause renal problems. And thus, if we are giving a triazole or we're giving amphotericin B, we need to consider this because if the patient was healthy, it's going to look much different than the patient right now in this severe disease state. We also need to consider liver toxicity and also QT prolongation. And one of the biggest interventions that pharmacists can do in these two diseases is consider therapeutic drug monitoring if that is available. And we want to do this on a weekly basis in these severely compromised patients. And we typically want to do TDM or therapeutic drug monitoring in our mold active azoles. So our posaconazole and our voriconazole. However, I do want to note that isovoconazole does not have a standard trough. So we really can't do TDM with isovoconazole at the current time. And we also want to consider drug-drug interactions. And one of the main reasons is that when we use these azoles, typically there's a big impact on our CYP enzymes when we use azoles. So we want to make sure we're looking at if it's an inhibitor and how that changes the bioavailability. So I just want to point out one on this list is if you look at the fourth bullet point, this dexamethasone, it induces 2C9, which actually may decrease voriconazole levels. So as a pharmacist, we should be thinking about these drug-drug interactions and how we can work with healthcare team members, our physician, our nurses, to make sure we account for this. And then also we look at 3A and 4 inhibitors may increase dexamethasone levels. So we got to make sure it goes both ways. So as a summary, how can we as pharmacists play a role in CAPA and CAM to hopefully limit the severity of diseases? So the first one that I want to point out is we need to increase awareness among clinicians, including other pharmacists, but also physicians, nurses. And we want to make sure that they are diagnosing these fungal diseases accurately and also reporting them to either their Ministry of Health or the proper chain of command, just so we have an idea of how prevalent and how severe these diseases are across the globe. We also want to be able to control modifiable risk factors. And two of the main ones that pharmacists can really have an impact on, both in an inpatient setting and an outpatient setting, is avoiding steroid overuse. And the other one is improved glycemic control. So make sure that we are controlling their diabetes so that we can hopefully decrease the incidence of CAPA and CAM, but if they do have it, decrease the severity. And finally, as I just mentioned, we need to consider pharmacological factors like therapeutic drug monitoring and drug-drug or drug-disease interactions. And this is a huge role that pharmacists can play, and this is what we're trained for. So I think we need to really start inserting ourselves into this. And that concludes my presentation for today. I really want to thank FIP and John and Dahlia for hosting us and letting us raise awareness of these COVID-19 complications. And I think we are on to questions now.
Thank you, Dallas, for such an informative presentation on a topic I think many may not be as aware as they need to be. Really appreciate your insight and expertise. So with that, just as Dallas suggested, we would love to take your questions, and we've left plenty of time to address questions. I've seen a number come in through the Q&A box. I know this is a topic that gets a lot of questions flowing. So I'm going to invite Dallas as well as Stacy. If you want to turn your camera on, we'll do a little Q&A panel here. And what I want to do is maybe, Dallas, start with you because you're already in your rhythm. We got a number of questions. One is, how can we adjust clinical practices to stem the overuse of antimicrobials to fight COVID-19 infection?
And this is a really great question because of course, we want to treat patients. We're worried about secondary infections after COVID-19, including bacterial, fungus, and origin. And the biggest way we can help our clinical practice is making sure that we are following guidelines, but also making sure that we're doing the appropriate tests, making sure that we're looking at specific tests, lab tests for each of these different entities. And I think that's going to guide therapy. Just like we're talking about our step-down therapy and antimicrobial use, we want to make sure that we're being appropriate in our broad spectrum, but also get down to our specific agents as soon as possible.
Thank you, Dallas. Stacy, I know you have been doing a really nice job answering questions in the Q&A box, so thank you for that. And there's one question you answered, but I think it would really benefit everyone to hear it live. Is there anything that we can do regarding post-COVID-19 complications? For example, losing the ability to smell or taste or fatigue. I know pharmacists get a lot of questions about how to potentially treat or ameliorate those types of symptoms. Do you have any advice for those listening in?
Yes, I think these are really common questions. And unfortunately, we're still so early on in really understanding what post-COVID conditions is and how to manage these symptoms. Luckily, most people's symptoms do resolve or begin to resolve to some extent. Within, a couple of months, most of the time. And I would keep a close eye on trusted websites like the CDC to sort of keep up to date on potential treatment options. But there are actually no current recommendations for drugs to be used for treating symptoms. It's actually recommended that we stick with already established symptom management protocols. So just simply treating the fatigue or the change in taste and smell with the normal drug of choice, basically, for that symptom.
Thanks, Stacy, and thanks for answering in the chat and then now live. And it probably is another reason why pharmacists and other health professionals really need to stay on top of the evidence here, because it's constantly changing. And so as therapies and treatments become available, pharmacists are going to need to know that and know that they're grounded in some type of evidence. So really appreciate it. Dallas, back to you. Have you seen any evidence or data around the impact of COVID-19 on antimicrobial resistance? I know you touched on mold, certainly, but what about the bigger picture of antimicrobial resistance related to COVID-19?
We haven't really seen a lot of evidence about it yet. We know it's happening just from a pharmacy perspective, a clinician perspective. But I think our biggest concern is we want to make sure we're treating these patients appropriately. So I think stay tuned, because I think there should be hopefully some good investigations coming soon about how maybe overuse of antibiotics or even antifungal agents, possibly based on colonization versus actual infection, invasive infection, and how that's playing into resistance and inappropriate antimicrobial use. And so I think we're going to be exploring that. But our main concern is, how do we treat these infections right now? Because they're so new and they're so significant that we're kind of focused around that right now. But stay tuned for more.
Yeah, thanks, Dallas. I know it's a really complex question. I know also FIP is so rightfully focused on managing antimicrobial resistance worldwide. So clearly there's some tie-ins here. Dallas, I'm going to stay with you, if that's all right. Can you talk a little bit about post-COVID-19 fungal infections being prevalent in different parts of the globe or region? So are you seeing this in different jurisdictions around the world more than others?
Yeah, and I think nowadays, it's pretty widespread globally, but especially with CAM, so COVID-19 associated mucormycosis, we really saw just a huge amount of numbers in India at first. And we still are determining why there was such a huge rate in India. But luckily, there's amazing individuals in India who are studying this. And so the rest of the world can be pretty prepared now, or at least as best as possible, because of the great investigations they've done. And so now we can identify risk factors, best treatment, best infection control guidelines because of them. As for CAPA really, so COVID-19 associated pulmonary aspergillosis, we saw a lot of those cases in Western Europe first, but now it's kind of spreading. We've seen a lot of cases in the US. We are seeing cases in, for example, Central America, especially with CAPA and CAM. So I think initially, yes, we saw them in certain areas of the world. And because of those great investigators and great clinicians there, they've raised awareness. And now we're seeing it globally. And hopefully we're improving outcomes from both of these diseases.
Thank you, Dallas. For those of you listening live, I continue to encourage you to submit questions in the Q&A box. We'd love to continue to provide you with the answers we can, knowing what we know today. Stacy, you answered this question, I believe, in the Q&A box as well, but because it's so important related to vaccination, I'd like for us to potentially address this one live as well. We've had a number of questions around people reporting post-COVID-19-like symptoms after receiving vaccination. Is this scientifically proven? What have you seen related to the use of the vaccine?
So I'm actually not aware of any current studies that show increased reports of symptoms after vaccination. Generally speaking, most frequently patients report improved symptoms or no change in symptoms after COVID-19 vaccine. Anecdotally, I have heard reports of individuals who have had maybe an increase in symptoms for a couple of days, but generally speaking, not these long-term post-COVID condition-like symptoms after vaccination.
Thank you, Stacy. I think that's a really important message, and probably speaks to the bigger role that pharmacists and health professionals play with regards to misinformation around vaccination and treatments. I mean, we have a really critical role to play as pharmacists to ensure that we're telling patients the facts and not necessarily contributing to the spread of misinformation or what the WHO has deemed an infodemic. So really appreciate you providing clarity. Back to Dallas, when we talk about, or when we look at CAM specifically, do you have any recommendations on prophylactic therapies to potentially prevent CAM in patients?
There's been a lot of great studies who have been looking at that. And this is actually pre-pandemic, just because can we prevent these severe and serious fungal infections? And the literature that I've seen in the last couple of years, there hasn't been great outcomes when you use prophylaxis therapy with either a triazole or any of our antifungal agents. So we may not be using it soon enough. We may not be using the right dose, but currently the evidence does not support prophylaxis. Hopefully, we have some newer agents coming onto the market. So pharmacists, please be aware, we have some new antifungals, which is really exciting. So those may be used for prophylaxis in the future, but at the current time, no recommendations for prophylaxis use.
Thanks, Dallas. I'm gonna stay with you if that's okay. When we look at different comorbid conditions as risk factors for CAPA or CAM, what have you seen in terms of uncontrolled or diabetes as a risk factor for CAPA or CAM?
Yeah, and this is probably one of the most interesting findings, is because traditionally we've seen that these fungal infections were more prevalent in immunocompromised individuals. And we've seen malignancies, we've seen other like severe immunocompromised states that lead to these fungal infections. What surprised us during this COVID-19 pandemic is that diabetes, uncontrolled diabetes, is a huge risk factor. And it does lead to some immunosuppression. And also fungus-like sugar, just like bacteria does. So it's going to grow better when you have higher blood sugar levels. So we've seen this as a risk factor in every single study. If you look at the literature, you're going to see in CAM, you're going to see diabetes, uncontrolled diabetes, as a huge risk factor. Now, it's interesting. We've been trying to look at what if they're controlled? What if it's controlled diabetes? And we definitely see a decrease in incidence, but even controlled diabetes, because of that immunosuppression aspect, we've still seen it as a risk factor, not near as high as uncontrolled diabetes. So we need to be thinking about diabetes as a risk factor, whether it's controlled or uncontrolled.
Thank you, Dallas. And we had a question just come in, which is a big one. So I'm going to open it up to both of you to potentially comment if you have thoughts. And the question is, how do we harness all the energy and vigor and passion that's been poured into the fight against COVID-19, but use that to develop a global AMR, antimicrobial resistance strategy? So how do we keep the momentum up as it relates to the potential bigger issue of AMR? Any thoughts?
Stacy, I can jump in first. So I think we're raising great awareness around inappropriate antimicrobial use in humans. And there's still a long ways to go, but I think we're doing a great job, and we'll continue to do a great job. I think as pharmacists, as clinicians, we need to start raising awareness from an environmental aspect. How are these fungicides or our other things that we use on crops and weeds, how are those affecting human health? How is that playing into antimicrobial resistance? And I think that's a huge gap that we don't truly understand. I think I mentioned before about specifically with Aspergillus fumigatus, we've seen that patients are acquiring resistant species that's very deadly from the environment due to fungicide use. So how is that playing out with different bacteria and different viruses and different fungi? And I think it doesn't seem natural for pharmacists to think about, oh, we should be looking at the environment. But as stewards of these antimicrobials, we need to start considering it, raising awareness and studying this more, or at least talking about it, I think is the first step.
So I'm going to echo basically what Dallas said in terms of awareness. I think that, COVID-19 has this silver lining that sort of has brought awareness to a lot of public health issues and also has increased funding for public health. And I think that for a long time, public health in general, which, I guess I would include antimicrobial resistance and certain awareness and in the public health realm. So I think that this silver lining of awareness and talking about these issues that are long-term issues, that are not issues that we're going to get gratification from immediately. These are marathons, not sprints. These types of conversations are sort of a silver lining that has come along with the COVID-19 pandemic. And hopefully we will be able to continue because we all have this experience to sort of come from as our baseline. We're able to say, this is what happened during this pandemic, and these are the things that we're missing, and we need to grow these aspects of public health and antimicrobial resistance programs. So I'm going to echo the awareness that COVID-19 sort of has brought about in our worlds.
Really appreciate both of your insights on that really large and complex question. Back to Dallas, we just had another question come in, and it's related to the use of cortisone and how it may impact the spread or proliferation of fungus infections. Do you have any insights related to how cortisone may or may not be used?
Yeah, so when we think about steroids like cortisone, we know it causes some immunosuppression. And when we have that immunosuppression, you're going to be more prone to getting fungal infections or bacterial infections, et cetera, et cetera. And the message here today is not to give steroids. Steroids are an important aspect of COVID-19 therapy. It's that we need to use them appropriately. We need to see what patients are they actually recommended for. And one of the big things we've seen is that steroids should be used in individuals who have low oxygen saturation levels. Individuals with a high saturation level, they may not be recommended for. And so this is really important from a pharmacy perspective, is you need to work with the clinician. You need to work with whoever's prescribing. And especially if you're an outpatient pharmacist that may dispense steroids, but you don't need a prescription, you really need to recommend them to see a physician, to see a clinician, to make sure that they're prescribed appropriate steroid therapy. So my message today is, please don't think I'm saying that don't give steroids. They just need to be used appropriately in circumstances. And this is a cool opportunity for pharmacists to really build those relationships with other healthcare professionals, to raise awareness of this and making sure it's prescribed appropriately.
Thank you, Dallas. No medication is without some inherent risk, right? So we got to be thoughtful about what we're giving and how we're giving it. Stacy, back to you with a question regarding any considerations for patients that may have asthma complications or asthma medicine as it relates to COVID-19 and post-COVID conditions. Have you seen anything related to those who have asthma and how that might complicate their condition?
So I do know that asthma as a comorbidity is a serious risk factor for developing post-COVID conditions. In terms of post-COVID conditions with asthma or asthma experienced as a post-COVID condition, again, most patients, the goal for management is really just to optimize the function and quality of life. And so the recommendations around post-COVID condition symptom management, including asthma, are to create comprehensive rehabilitation plans. Many post-COVID conditions can be improved through establishing symptom management approaches. And evidence does suggest that a holistic approach for patients throughout their illness can be beneficial. Patients with post-COVID conditions might benefit from a review of their current preventative care measures. So just having basic discussions about nutrition, physical activity, sleep and stress management, interpersonal relationships, and chronic disease management can actually improve post-COVID conditions, including asthma. And also, it's important to consider age-appropriate preventative healthcare screenings that may have been delayed due to the pandemic, and make sure that their current dosage of treatment and screenings are up to date for their care plans.
So Stacy, you just slipped in a few really important points, I think, in that answer. One is always consider non-pharmacological therapy to augment or even replace pharmacological therapy. The other is don't delay preventative care because that really does obviously set the stage for how well you can fight disease later on. So thank you for that. Dallas, back to you. Can we talk about why there isn't therapeutic drug monitoring in CAPA or CAM for amphotericin B? And you may have already addressed this, but perhaps you can answer that question now.
Yeah, so when we talk about therapeutic drug monitoring, it's a really great intervention that pharmacists have a great role in. And we use this quite frequently, and there's really great guidelines out there to support TDM for voriconazole and posaconazole. But when we look at amphotericin B, which is a very, very old medicine, like 60, 70 years old, I think, I probably older than that, maybe even, it's not recommended, which is interesting. And the reason is because the pharmacokinetic and the pharmacokinetic profile isn't really well understood. So we don't even know what trough to look at because of lack of research. So if any pharmacist is willing to do some studies out there, I think it'd be great to look at what could be a good TDM monitoring protocol for amphotericin B. But I also want to mention that depending on the part of the world and depending on what form of amphotericin B is available, whether it's liposomal versus the older one that has lots of problems with kidney problems, it's probably going to look different because one is more bioavailable than the other. So I think there's a lot of challenges in determining a proper a trough or a proper level for therapeutic drug monitoring with amphotericin B. But hopefully some studies will come out of this pandemic, and because more frequent use in CAM and CAPA, that might support the use of it.
Thank you, Dallas. Yeah, I was curious about that myself with the drug being so old and being around so long. There was a clarifying question, Dallas, for you, just about the strain of Aspergillus that you mentioned. Could you repeat what strain it was?
Yeah, so there's actually quite a few strains that cause Aspergillosis that stems from the Aspergillus species. The one most common and the one we're most concerned about is Aspergillus fumigatus. And this is the one that has that resistance that we're really worried about. And it's also the one that's most likely to cause disease. So that was Aspergillus fumigatus.
All right. That was one of the best Q&A sessions that I've been a part of in a really long time. So I really appreciate all of the questions from those listening live and certainly the wonderful answers from our presenters. While we start to wrap up the session today, I'm going to ask my colleagues at FIP to share the last slide, the concluding slide, just to close out today's session. And if that's possible, wonderful, thank you. While that slide is being shared, I would like to sincerely thank our panelists, Stacy and Dallas, FIP, as well as our wonderful coordinator for this event, Dahlia. The recording of this episode will be made available on www.fip.org. If you are not a member of FIP, let me take this opportunity to encourage you to join our wonderful organization. We put on so many wonderful events. There are lots of resources, and that way you can be part of the pharmacy voice worldwide. Please give us feedback to webinars@fip.org so that we may continue to improve our digital event offerings. With that, I want to wish you a very good day, good morning, good afternoon, and good evening. Thank you very much for your participation today.